Good afternoon. My name is Helal Syed. I'm one of the urology residents over at the Brooke Army Medical Center. That's part of the San Antonio Uniform Services Health Education Consortium. My presentation today is taking a look at penile rehab. So specifically, it's a randomized controlled clinical trial of erectile recovery after robotic-assisted laparoscopic prostatectomy and interim analysis. I have no disclaimers. Erectile dysfunction after radical prostatectomy is a known complication occurring anywhere from 25 to 100% of patients undergoing the procedure. This is primarily due to the multifactorial nature of the disorder, patient characteristics such as age, stage of cancer, and preoperative potency, as well as the experience of the surgeon and whether nerve-sparing technique was used, all play a significant role in postoperative erectile dysfunction. The majority of data thus far investigating patients who have undergone open or radical retropubic prostatectomy and the use of PDE5 inhibitors after surgery has shown improvement in the recovery of erectile function. However, these days, radical prostatectomy is more commonly performed using a robotic approach, but to our knowledge, similar large-scale erectile function studies have not yet been performed in this cohort. A more recent study published in the Lancet journal comparing the two approaches showed similar functional outcomes at 12 weeks, and thus it would leave one to posit, could PDE5 inhibitors show improvement in patients undergoing RALPs as well? One of the issues with PDE5 therapy is that it is costly. For beneficiaries in the TRICARE system in which I work in, it can be a substantial cost to the government and taxpayers. In fact, in 2015, $82 million was spent on PDE5 inhibitors alone. So this leads us to ask the question, is there an alternative agent that we can use instead of the normal PDE5 inhibitors that are currently being used? Pentoxifylline, which goes under the brand name Trental, is a xanthine derivative that has been used for patients with peripheral vascular disease or for intermittent claudication. Of note, caffeine itself is also a xanthine derivative as well. Pentoxifylline is a PDE3 and 4 inhibitor and works to reduce the viscosity of blood and improve oxygen delivery to tissues, and as such, in theory, would increase oxygen delivery to erectile tissue, nerves, and supporting structures. In fact, in a rat model, it significantly improved erectile dysfunction after cavernous nerve crush injury. To date, it has been studied in humans with vasculogenic erectile dysfunction, but not in those in the post-radical robotic-assisted laparoscopic prostatectomy setting. Side effects of pentoxifylline include GI distress as well as dizziness and lightheadedness, which are usually the minor side effects. The major side effect, which is exceedingly rare, includes hypersensitivity reactions as well as bleeding. But most importantly, in relation to the study of note, it is significantly cheaper than sildenafil or Viagra, for example. So this brings us to our objective. This sildenafil citrate therapy or pentoxifylline promote improved erectile function as compared to placebo in RALP. For our randomized controlled trial, we plan on recruiting 240 subjects undergoing nerve-sparing RALP. Our exclusion criteria includes those on current nitrite or PDE5 therapy, inability to take nitrates, significant cardiovascular disease, and those with an erectile function domain score of less than 21 on the IIEF. Each subject is randomly assigned in a double-blind fashion to one of 3 treatment arms, as listed there. In addition to basic demographics, measurements of SPL or stretched penile length and IIEF scores, as well as sexual activity, were measured for the follow-up period of 1 year after surgery. As of September 2019, 30 subjects have been enrolled in our study. 7 of these subjects have discontinued for various reasons, the most common ones being GI distress and not wanting to take so many pills. Of the remaining 17 have completed the 12-month trial. Now moving on to demographics, there are 6 patients in the placebo group, 5 in the pentoxifylline, and 8 in the sildenafil group. For age, BMI, and race, there was no statistically significant difference between the groups. In the preoperative setting, there was no statistically significant difference between the interventions for transrectal ultrasound, prostate volume, stretch penile length, and IIEF scores. There is no statistically significant difference between pre-surgical and post-surgical measurements for the above data. There was also no statistically significant difference for the above measurements between the interventions as well. But I would like to reiterate that our sample size was small. Looking at additional postoperative data, there was no statistically significant difference between pre and postoperative measurements in IIEF for all the intervention, and specifically IIEF scores were decreased after surgery. Once again, there was no statistically significant difference between the treatment arms themselves, but once again, though, the sample size was small. So in conclusion, given our small sample size, our results are not powered enough, and thus further research is needed. But given the data thus far, there is no difference between interventions for IIEF, BMI, or stretch penile length. And IIEF scores across the board were decreased 1 year after RALP. And that concludes my presentation.